The first speaker in this session is Mercedes Rodriguez Celin. She is a pediatrician with a specialty in growth and development. She's worked as a clinician researcher at Shriners Hospital for Children in Chicago. And as you heard earlier today, she was involved in several multi-center studies to improve the knowledge about the function, surgical, and pain status of patients with OI. And her talk is titled, How to Assess Pain, Pros and Cons of Different Tools.
Okay, hi again. So the idea of this presentation that Ingun asked me to give is about, we will go through about some pros and cons of different tools that evaluate pain. And we will try to, I will try to give some little tips is in a very difficult topic, but thankfully there are many speakers that will go through different tools, so that's something good. So the idea is to speak a little bit about some tools that can help us assess pain in children, in adults, and some tips and things that I like to think when I go and I read a clinical trial. So first of all, I thought that it was important to start with the definition of pain. I know we have been speaking about this, but that is this definition, I feel, explain why we need to assess pain in a multidimensional way. And this is because pain is a multidimensional experience. It's an unpleasant sensory emotional experience. And as you know, it is influenced by many different factors, biological, psychological, social factors. Something that is important is a person report, is an experience and should be respected. And we have been already speaking a lot about that. And pain may have adverse effects that affect function, social, and psychological well-being. So that's why we need to do a multidimensional evaluation of pain. So when we ask about pain, what we usually do or what we usually know is about the intensity, and that's what doctors we use to ask how much, 0 to 10, but there is a lot more to ask and a lot more to know about pain. So it's not only the intensity, but it would be wonderful to understand what is the cause of pain. And I was just hearing, I don't know why my pain is, it doesn't look like this or it doesn't look like that, and that is very difficult sometimes to understand, but it would be wonderful if we know why is the pain so we can help better. Of course, location, the quality of pain, the quality speaks about the characteristics of pain and how this is affecting the person, and it gives a lot of information to understand and to better help if the patient has coping strategies or not, and if they are working on which ones are then. If they are receiving treatment or no, I said that there are participants that are not receiving any treatment. And if they are receiving a treatment, is this working? What is the response to that treatment? So these are some of the things that we can evaluate when we evaluate pain. So I was looking through PubMed, and I feel like it's logical or that we don't know a lot how to assess pain. If you see the publications, only in the last 2 decades, this has been something that is in PubMed. So we are just learning, I think, about how to assess pain or what is pain or how do we treat pain. And this is true for children and for adults. Of course, it's worse for children, but we have less information, but this is something new for us too, as physicians. So which tools should we use when we are assessing pain in children? And they are, I would like to recommend the recommendations. So there is the PEDI impact. The PEDI impact is a consensus of investigators that meet and say, okay, if we are going to do a clinical trial, which are the best tools? So I feel like we will need to try to follow the recommendations because they are recommending only validated tools, and that has been use in different conditions. So, and of course, it's different when we assess, the recommendations are different. You can see if we are assessing acute or if we are assessing chronic pain. Pain intensity is important for both things, but you can see that, of course, role functioning, emotional functioning, this will be more affected, or sleep or economic factors. Well, probably in a chronic condition, there are factors that we need to take more into account. So when we speak about pain intensity, we know that pain intensity is very useful always, but it's more useful for acute pain, and maybe in a chronic condition it doesn't change a lot, no, between 7 or 8, but or 6 or 7, but you know, it doesn't give us a lot of information, but it's of course very important when we are evaluating acute pain. It's important to follow up if we start a new treatment, or to see the response of treatments, and these are the scales that they recommend, and everybody knows about the visual analog scale, the phases. So depending on the age, there are different tools that we can use. Evaluating pain in babies is very, very difficult, and everybody knows that, and we try to understand their behaviors. These are the scales recommended. I only brought the FLAC scale. That is the one that we usually use in the NICU when we are evaluating babies, but especially when we try to see what they are doing, if they are crying, if they are moving, how is their heart rate, how is their face, and Dr. Bober will later speak a lot more about this, I'm sure. So when we are evaluating chronic pain, the intensity might be different. We will want to ask the number of days free of pain, or on the other hand, how many days of the month did you have pain. So this is like a different measurement, and it's important that we take this into account. And also when we are evaluating chronic pain, pain diary seems to be helpful to understand and to keep track what is happening. And this is a methodology that has been recommended, and the idea, these are methods to try to understand pain and its fluctuation, because maybe it's not the same today than tomorrow, and to capture real-time data, and also to improve things that, you know, the recall bias. Maybe you go to the doctor every 2 to 3 months and you don't remember what happened some time ago. So there are some electronic diaries too, and I brought an example that I found on my phone, and we are recommending patients to use different apps, trying to keep track of what is happening. This is called Soma, but it's not that this is validated or anything, but the idea is that we need to ask, and we need to have something that is handy and that it help us know what happened like some days ago. And also these apps ask different things. How are you feeling? They try to evaluate, to integrate pain with different things, or how is this pain so bad that is preventing you to do this or that? Where is the pain? How intense is your pain? And also the feelings associated with this. So, and also there are some research that is coming saying that using these pain diaries is not only helpful because you keep a better track of what is happening, but also it helps recognize the situation and also improves the communications with your providers, with your physicians. So it seems like the use in itself it can improve the mood, and it is something that is already an intervention, because we are asking, we are keeping track of what is happening. And I'm sure that if you are using one of these and you see that your pain, it was a 6 and then it's a 7 and then it's an 8, okay, I have to do something, or I have to change what I am doing. So it sounds interesting, and of course there are still studies that need to show the real intervention, but I feel like we are moving towards there. So as I said, the recommendations is not only to include pain intensity, but also to analyze or to see what is happening with functioning. So this consensus recommend different tools. That one is the functional disability inventory, one is the PET-SQL, that is a multidimensional scale, and I know I'm sure most of you heard about this because it's good because evaluate physical function, emotional function, social function, and school function. Is only for children. I wrote here some examples. Here is the functional disability inventory. So the idea is that it asks how much, if the different activities are difficult for you or not. It's not directly about, asking about pain, but it can give you an idea of how difficult things are for this kid. And when we use PET-SQL, that is a tool that I use many times, is a great tool. The only con is that it only asks one direct question about pain, and the rest is, you can have a lot of information, but related to pain only. Question 7 is directly related to pain. So when we want to evaluate also emotional function, there are many different scales. I only brought the children depression inventory because it's one we use most. PET-SQL, as I said, also evaluate emotions. And the APPT, the adolescent pediatric pain tool, I will stop a little bit on this one because I think it's a great tool. The APPT, in one page, you can have a lot of information. The idea is that the individual with pain can mark where they have pain, so you can know about the location. It will give you also information about how many sites are affected, and then they have to complete a scale, so you will know about intensity. And there are also many pain descriptors that you can see here that the person can circle and show, and this will give you information about the quality of the pain, about how pain is affecting behavior, and also the temporality of pain. So the APPT has been validated in OIFE. It's a multi-dimensional self-report tool that, as I said, it gives lots of information and describe pain, but also the experience of pain, because it asks about all the emotions associated with pain. Has the potential to distinguish between nociceptive and neuropathic pain. And the cons for this study, for this tool, is that it only validated between 8 and 18-year-old. If you go to the literature, they have been used for many other age ranges, but has been validated for this age, and is time-consuming. Some authors describe up to half an hour, but there are others that describe that they were able to use it in 3 minutes. So it seems like it has a wide range, and maybe depending on the age, and the younger kids might need help to complete this tool. So this tool has not been recommended by the PEDI impact, that is this consensus where I'm basing my talk, but it's a new tool, so I thought it was good to bring it, and I think it has a lot of potential. The STEMS, that is a screening tool for everyday mobility and symptoms, and I will speak more about this in a next talk. The good part of this tool is that it's easy to use. The idea of this tool, it asks if activity and mobility is limited by pain or fatigue. So it's not only ask about pain, but also about fatigue, and I think that that it's perfect. And also ask about the use of different mobility devices. So you can integrate these symptoms also with the mobility devices, and also ask all these symptoms in different scenarios, in different environments. So if how things are going at home, how things are going at school or work, and how things are going in the community. The cons of, and the good thing is in English and Spanish, and the cons of this study that only evaluate the presence or absence of the symptoms. It's like a screening tool, and does not measure intensity, location, or quality of pain. Moving to adults, only some suggestions. I brought 2 big tools that I think that are good, very good. Everybody knows about PROMIS, and I know that there is a talk later today about PROMIS too, but PROMIS, for the ones that they don't know, is a is a tool that is also a multidimensional tool that measures physical, mental, and social well-being. As you can see, these are all the categories that might be assessed with PROMIS, and they assess pain behavior and pain interference. So these are some questions as examples of pain interference and pain behaviors that may be assessed using PROMIS. The pros of this tool is that it can be used across lifetime, so in children and adults. So that's great when you are following a patient from a long time. It's very good that you can continue using this scale. It measures the intensity of pain interference in many aspects of life. You can see how they are asking how pain affects different things, not only not in a general way, but is interfering you with your work, with school, with social, and that's important. And also pain behavior is what is pain making you do, or how is pain making you feel. And so that is very important. So give information about different dimensions. There are cut versions that are these short versions that you can complete using an iPad. Is validated in OI, so that's we can't ask more than that. It's available in many languages and is also recommended by the IMCAT. The cons is that they don't ask specifically about location, and it is not helpful for discerning between somatic and neuropathic pain. But there are many studies. If you put PROMIS in PubMed, you will have like thousands of publications, and there are some that are good, I think, because they showed how PROMIS is correlated with pain intensity. So it's good to measure. They use PROMIS, they use a validated scale of pain intensity, and they show the same results, and the same with physical function scales. It seems that is highly correlated with all this, so that's very reassuring. The next scale, and the last one that I will show for adults, is the pain quality assessment scale. I like also this tool because in 20 questions is ask a lot of things, and you have a lot of information. It's also recommended by the IMPACT 2016, and in all different questions measures the intensity of pain. You can see that each of the questions had a scale, measures pain descriptors, so we will have information about the quality of the pain and the experience of pain. And also the temporality. If you see the last question is asked about intermittent pain, variable pain, stable pain, and that is also helpful when we are trying to plan for an intervention. It does not give information about location, that the cons, but I think it has also lots of pros. So some tips about clinical trials. I know there is also a talk. It was good because everybody's speaking about all these too. So some things. So what I can suggest, of course, is to follow the recommendations. We have recommendations for pediatric population and also for adults. The adult one is newer. It was published in 2016. So if you are planning on doing a clinical trial, of course, you need to see what are the validated tools and the recommended tools for planning a type of study like this. But I was surprised and not surprised, but the IMPACT also published this study where they show how difficult it is to get a study, so a drug available and finally being used by individuals. And there are many things that has to do with this, but some of them might be related with deficiencies in the quality of the clinical trials. So I think it's important, if you are doing a clinical trial, try to see what things to avoid and what things to do better, because we may lose the opportunity of knowing what is happening, or if a drug is working or not only a drug, but also any other intervention. And some of them there are areas of improvement, and some of them are related to the study design, and that is directly related with the tool that you are using to measure pain. So that's why it's so important when you pick the tool that you have this in mind. And this will have to do with the age, it will have to do with the time that you have, it will have to do with the intervention you are doing, so it's not the same depending what you are using. Also to be trained, because all these tools you need to know how to use them and how they have been designed, and the ages, and how often are you supposed to measure pain also, and the data collection, of course, is super important. So when I am reading a clinical trial that is related to any of these, I try to think, the first thing is what they are measuring is meaningful for patients, because this is the big question. Of course, yes, they found a difference. Is that make any difference or not? And the type of measure. Are these measures that are showing patient's perspective, or is only a clinician outcome? Because that can also make a big difference. So, of course, I will always prefer studies that include patient's perspective. Of course, performance outcomes could be very useful too if you are measuring how many meters a patient can walk before and after an intervention. That is something very objective, but it's also very useful, even though it's not the perspective of the patient there. So I feel like if I have to choose clinical assessment outcomes, I will choose patient-reported outcomes and performance outcomes. But sometimes the only thing that we have is the observer, and if that's what we have, is that what we are going to use? But it's good to be aware when we are reading or we are planning to do a study to know where the information is coming from. Another problem that we have with pain is that usually it's not measured as a primary outcome, but a secondary outcome. When I was doing the systematic review about pain, most of the study, they are not asking about pain. They are asking about mineral bone disease, about fractures, about this or that. So if the study has not been designed to find difference in pain, maybe the power of the study is not good enough to do that. So that's something that we need to be aware when we are reading and thinking, okay, this doesn't work. Maybe it doesn't work because the study was not designed for that. So that's something also to have in account. And also the intervals of measuring pain is adequate or not. So there are some studies that measure pain 1 year later. I don't know if it worked at that moment or if it didn't, or they are measuring pain too soon, and to see a result you need to wait more. So all this is important when we are analyzing information and we are planning to do trials. So I know that you wanted me to ask which tool should I use, and I'm sorry, but I show you many different tools and I do not have that answer because it's complex, and also we need to focus this in OI, and not all our objectives will be the same. So we know that there are no perfect questionnaires, all has pros and cons, and there is not one that fit all the needs that we have. Because we know that there are different types of pain, different ages, different frequent or not so frequent evaluation, clinical setting. It's not the same what we expect from a tool that will be used in the clinical setting that from a research setting. And do we want to measure only pain, or we want to measure other aspects of the person's life? And a multidimensional tool will be more useful. So it depends what we want. But what I can recommend is to use a scale that is developmentally appropriate. So that is, if it was developed for children, use it for children. If it was developed for adults, use it for adults. Try to use validated tools. Sometimes it's not possible because what we want to measure is something very specific, but if you can, try to use validated tools, multidimensional tools, of course, because we know that pain is a multidimensional experience. But the most important thing is to be consistent in pain evaluation. Remember to ask about pain every time you meet with a patient. Try to track what is happening over time. Do not think that the patient will tell you about this, because people sometimes do not speak about this. So that's the most we can do, is to be consistent on what we are doing. So with this, I finish, but of course, I'm open for questions. I want to thank the OIF for this invitation, the opportunity of being here, sharing this with you, the OIF, because of their support. And I brought you two pictures, one from Chicago, where I'm living now, but one from Argentina, where my heart belongs. I hope you can visit. Both places are very beautiful. Thank you.
Thank you, Mercedes. You gave us a great overview of tools, and like you said, it's complicated.
Yes.
So are there any questions? Teresa.
I must say, my country, Switzerland, is not so very well represented here. But I just come from a meeting last Thursday where the topic was involving patients in research and action, but in research primarily. Do you know, I mean, this means involving patients from the study design until the publication, representative of patients. Do you know something about that in your clinical, do you have some information in your clinical trials?
That is the best thing we can do, is to involve patients since the beginning, to know what they want, what they need. That should be our first question. What is missing? What we are missing? What we can do better? And yes, we are trending to include patients since the beginning in the design of every study, not only clinical trials, to listen their voice. Yeah, thank you for bringing that.
And Ariane.
Thank you, Mercedes. So really, really good talk. And to show us a good overview over all the questionnaires. What do you think about the negative effects of the diaries? Because it's something when you like scan yourself and when you focus every day on pain and fatigue and all these things, there is a risk that you actually get worse. So what do you think about this?
Yes, it can be overwhelming to, receive this alarm. How is your pain? Oh, I was not thinking in my pain. Like, yes, I get that. Really, what I found in the literature is that it can have like a positive effect, not a negative effect. But I was reading in one of, the patients were saying in one of the presentations, I prefer not to speak about that. And that's something respectable too, it's like, and we found like in our study, 11% of the participants were not receiving treatment. And I asked why. Maybe they don't want, or maybe we forgot, so I don't know. And there are studies that show that that percentage is even larger. So yes, I don't know. And when I presented the pain diaries, I was sure to put we still need to do studies on this. There are not really studies well performed. These are experiences. So I put that in my slide because this is the beginning of something, I think.
Is it time for a question? Okay.
One more, and then...
Yeah, I have a comment on the pain diaries because we asked about that in the OIF and OIFE survey. So we do have data on who are willing to fill in a pain diary and how long. But my question is, did you also consider the cost of these tools? Because some of these tools are behind paywalls, and especially if you want the tool in different languages, it costs a lot of money for the trial or the hospital.
Yes, well, I put free pain diaries there in my slide because, yes, I am aware of that. The problem with this thing that I was just showing, like, okay, we have things that are new and we are trending to that, but I don't know and the research doesn't know, is how the physicians can track that, because this is something like a personal thing that it can help you to have more information about you and then to communicate better and maybe to do an intervention by yourself before. But this is not, these apps that I was showing, this is not something that you can share so far, what I know, with your physician. So there are other methods where you can keep track. but someone needs to be checking that too, because if you are putting information there and nobody is being aware of that, you know, I am speaking about a hospital system, that is also something that it could not happen. So yes, I feel like all these things need to have a lot of more evaluation and research coming soon. Yeah.
Mercedes, thank you very much indeed.
Thank you.
And yeah, thank you. Thank you for a really interesting talk.